Welcome to Biocanic's Health Intelligence Exchange community, where leading practitioners in integrative health approaches will discuss how they solve the most challenging and common health issues. These regular Q&A discussions are designed to take a deep dive into case studies and integrative approaches in order to elevate the collective knowledge of both experienced and new practitioners alike. Biocanic's Health Intelligence Exchange, your community for functional medicine.
Welcome to the Health Intelligence Exchange, everyone. I'm Lainey Gray, Strategic Accounts Manager with Biocanic, and today I'm joined by our guest, John Neustadt from NBI Health. We'll be exploring how to prevent and reverse osteoporosis with a whole person approach. Be sure to subscribe wherever you're watching or listening so you never miss an episode. And for those of you who are joining us live, we will be moving into a Q&A session toward the end of the conversation. So feel free to drop your questions into the comments at any time. John Neustadt is the founder and president of a dietary supplement company, Nutritional Biochemistry Incorporated, NBI and NBI Pharmaceuticals. Dr. Neustadt founded NBI in 2006 after he couldn't find products that contained the amounts of nutrients shown in clinical trials that he needed for his patients. He received multiple U.S. FDA orphan drug designations for potentially treating rare diseases using natural products through his company. NBI Pharmaceuticals. Dr. Neustadt hosts the Delivering Health podcast, is a member of the Bone Health and Osteoporosis Foundation's Corporate Advisory Roundtable, has published 5 books and more than 100 research reviews. The world's largest medical publisher, Elsevier, recognized Dr. Neustadt as a top 10 cited author in the world for his work. Dr. Neustadt earned his naturopathic medical degree from Bastyr University. Thanks so much for joining us, John. Let's jump right in.
Thank
now,
you.
Before we get going, let's set the stage. When you take a whole person approach to osteoporosis, what does it actually mean clinically, and how does that differ from the standard care model?
The conventional model, when it looks at bone health and osteoporosis, is typically focused on improving a test number, the bone density test number or DEXA scan number. That's only one piece of a much larger puzzle. When you talk about, or when we talk about how to serve our patients the best way we can, we have to necessarily look beyond just a number on a test, because the risk with bone loss and osteoporosis is that somebody breaks a bone. If you're a woman with osteoporosis and you fracture a hip, there's up to a 36% chance that you're going to be dead within a year. And those people or more never recover their full pre-fracture level of mobility and pain-free lifestyle that they had before. And a good number of them, a significant percentage of them, require ongoing care just for the daily activities that we all take for granted, like brushing our teeth or going to the bathroom or showering. And they can continue to need that care. In fact, debilitating chronic pain in the elderly is often caused by fractures. And a woman's lifetime risk of an osteoporosis fracture is equal to her combined risk of breast, uterine, and ovarian cancer. So it's not just a matter also of that this can kill you. And it's also a matter of quality of life and being able to enjoy the years that we have here. And so when you look at a bone density test result or any test, it's only as valuable as it is at predicting fractures. And what the research shows is that a bone density test only predicts 44% of women with osteoporosis who will fracture and only 21% of men. So the whole person approach necessarily means looking beyond those test numbers to see what else the research shows we can do to promote healthy bone density and maintain bone strength.
I love that, because too often we see in the medical model that we're looking at a test result and then we're acting just based on a test score. And you're bringing in right from the get-go, we need to look at different parts of the lifestyle and how we bring those all together for that whole person approach. And to your point too, this is a big deal. When we have broken bones and fracture risk as we get older, that really does impact the quality of our life. And we sometimes don't think about that in our 20s, 30s, 40s, would you say?
Oh, absolutely. Absolutely. And that's not uncommon though. I think
Yeah,
for people in general, we don't tend to be, we're in the general public tend to be preventively minded. If you're not in pain or you don't have to think about it, most people assume it's working well.
right. Right. Okay, so let's talk about some of those nutrients. Most people know about calcium and vitamin D, but what are the most significant and under-recognized drivers of bone loss that practitioners consistently miss?
There's a couple categories that I kind of consider this. One is, what does the research show in terms of diet and dietary pattern? Because that's the foundation of long-term health. What the habits we have every day of what we're eating, what we're consuming. And then I look at, what do clinical trials show with respect to isolated nutrients in that can be found in dietary supplements. So first with diet, I think one of the biggest misconceptions with osteoporosis is that you just need to emphasize calcium-rich foods, and that's all you need to do. Get your calcium. You hear that a lot. In fact, the FDA is approved as a label claim for calcium as a dietary supplement. Calcium, a lifetime of healthy calcium intake may help prevent osteoporosis. But the reality is, we have to look beyond that, because it's not just minerals in bone. When you're looking at diet, it's the overall dietary pattern. Other minerals like magnesium are important, and they have been associated in terms of diet with bone loss. One of the big overlooked things, though, is protein, is getting enough protein. The research is quite clear that bone is a highly protein-dependent tissue. I mean, like all tissues, there's different elements in the bone. So there is the mineral component, like I mentioned, calcium, magnesium, and other minerals. But then there is the non-mineral component of bone, or the extracellular matrix, which is comprised of proteins. There are 180 to 200 different proteins in bone. And in fact, it's the protein, the structural protein in bone, which is collagen, predominantly type 1 collagen, that gives bone its ultimate strength. If the collagen in your bone were to disintegrate and not be there, it would be brittle, just like a column of chalk. But it's the collagen that gives bone its ultimate strength and flexibility, and the minerals bind to it. So strand for strand, collagen is stronger than steel. And when bone is healthy, when collagen is healthy, and somebody falls, when they hit the ground, the bone is able to absorb that impact over a larger volume of bone, and that bone can actually deform a little bit. It disperses that impact because the collagen is flexible. And so it's able to disperse that through a larger volume of bone and not break. It's more resilient. And what is the foundation of building collagen? It's protein. I said that there are 180 to 200 proteins in bone, in addition to collagen. And I see it quite often, and the research supports this, that as people get older, they're not consuming enough protein to maintain healthy bones. The amount of protein somebody consumes can account for 2 to 4% of bone mineral density. Just that alone, just protein. And I've seen lots of recommendations of really high, like 1 gram of protein per pound body weight per day. For me, for myself, looking at the research, I don't think people need to go that high. There's just no evidence in the research to support that with respect to bone. What the research does show is that consuming about 0.6 grams of protein per pound of body weight per day should be somebody's minimum. Now, that's more than the USRDA. So as people get older, they need more than what that minimum government recommendation is to maintain strong muscle and strong bone. And so I see that a lot, that people are not getting enough of that nutrient, protein, during the day. And then in terms of overall dietary pattern, what we know is that the Mediterranean dietary pattern, which is essentially a plant-forward diet, it's been studied for 50, 60, 70 years, decades. I've never seen one negative study. Every study that I've seen that looks at this dietary pattern has concluded that it is associated with reductions in osteoporosis. In fact, a 20% reduction in osteoporosis, a 20% reduction in hip fracture risk, which is the most dangerous type of fractures, and reductions in cancer risk, all-cause mortality, cardiovascular disease, dementia, diabetes, obesity. I mean, the list just goes on and on. And so, like I mentioned, that is a plant-forward diet. And I break it down in my book, Fracture Proof Your Bones, and other articles that I've written into a very simple system to help people transition into eating this way, which, by the way, is not only healthy for bones, but also is important for whole health, for all of those other risks that people have that I just mentioned. And so what I recommend people do is they consume 30 grams of dietary fiber per day, because where's that fiber found? It's found in those fruits, whole fruits, and vegetables that have calcium and magnesium and other plant antioxidants and nutrients that our biochemistry and our bodies need to thrive and function optimally. And then on top of that, I have them calculate how many grams of protein based on their body weight they should be consuming per day. And then I help coach people and recommend they transition into eating that way over about 6 weeks or so, whatever's comfortable for them, because it often requires shopping differently, having different snacks in the house, cooking differently, maybe using different spices. And large changes done quickly tend not to be sustainable. So this is about developing new habits that can help sustain you for the rest of your life, because with every spoonful of food, you're either feeding the disease process or promoting your health. And so that's on the dietary piece. When I look at dietary supplements, then what we see, though, is that when you take isolated nutrients out of food and you put them into prospective clinical trials, it disproves the conclusions of some of those dietary studies. So let me give you an example of that. Magnesium is a great example. So there are multiple studies showing an association in diet of consuming adequate magnesium and bone health. There's an association with low magnesium on blood tests and bone loss. But when you take the magnesium as an isolated supplement, there's only one clinical trial from the 1990s that showed that it could improve bone density, but there are no fracture outcomes data. And so when I look at these nutrients in prospective clinical trials, I'm asking myself the question, okay, does it actually show the benefit that we want in terms of a whole person approach? Should we be emphasizing more food sources for that and limiting dietary supplement recommendations to just those nutrients that have been shown in prospective clinical trials, not only to promote healthy bone density, that's what we want, but most importantly, to maintain bone strength. And the most sensitive indicator, the most important indicator of whether our bones are strong is if a bone breaks. So I'm looking at these clinical trials and the research that have fractures as the outcome. And there are only a few nutrients that have been shown to reduce fractures in prospective clinical trials as isolated nutrients. So calcium and vitamin D. And people tend to get, I think, too much calcium. They don't need 1,000 or 1,200 milligrams per day as a dietary supplement. The USRDA for women is 1,200 milligrams per day of calcium and 1,000 milligrams per day for men. Now, if you're eating the average American diet, which frankly isn't that healthy, hopefully you're eating better than that. The average American woman consumes about 800 milligrams of calcium in her diet, and the average American man gets about 1,000 milligrams in his diet. So for most men, they don't really need extra calcium typically as a dietary supplement. For most women, since they're consuming, maybe 800 milligrams in their diet, a dietary supplement with about 400 milligrams of calcium is sufficient to get them into that USRDA range. There's no evidence that getting more than that is healthier for bone. And in fact, there's some toxicity that can occur with too much calcium. The Bone Health and Osteoporosis Foundation and the American College for Preventive Cardiology, their current position statement on calcium consumption is that it should not consume more than 2,000 to 2,500 milligrams of calcium per day from all sources. And that's important because a lot of times people go into their doctor and they're concerned about their bones. They're told to take calcium and the doctor just says, well, take 1,000 or take 1,200 milligrams of calcium as a supplement, not taking into consideration their entire diet. Again, more of a whole person approach. And so people can be getting up to that, dangerous level, which we want to avoid, obviously. And then you want to pair it with vitamin D to ensure that vitamin D levels are appropriate. A lot of people have vitamin D insufficiency. Their vitamin D is too low. I'm personally a fan of testing vitamin D and seeing where it's at, because maximum hip fracture reduction for vitamin D is associated with a vitamin D level of 30 to 44 nanograms per milliliter on blood tests. Now, for immune health and other systemic benefits, a lot of clinicians, myself included, want that higher, 60, 70, 80. But if we're just talking bone health, looking at a bone support dietary supplement, to get to that 30 to 44 nanograms per milliliter level on blood tests, taking 2,000 international units of vitamin D3 per day is sufficient to get most people into that range. And then the third nutrient that I think is very powerful is a specific form of vitamin K. There's a lot of confusion about vitamin K out there. I've given continuing education talks on this, clarifying the vitamin K confusion. And I'm really passionate about helping people understand that vitamin K is not just one nutrient. It's a category of different nutrients. There's vitamin K1. Vitamin K1 is known as phyloquinone. It's found in green leafy vegetables. And this is a great example as well of a nutrient that, when you look at epidemiological data and people are consuming it in food, it does show an association of improving bone density. But when you take it as an isolated dietary supplement, vitamin K1, there are clinical trials on it, and the clinical trials show no benefit. There are two clinical trials using vitamin K1, one at 5 milligrams and one at 10 milligrams per day. Bone density loss was not stopped. It didn't stop bone loss. It didn't improve bone density. And one of the two clinical trials also evaluated fractures as the outcome, and it showed no benefit. And yet, if somebody's getting it from food, the more vitamin K1 they take, it helps reduce that fracture risk. And I think that's because when it's in a food matrix, when it's in a whole food, it's not just the vitamin K that's there, it's all the other supporting nutrients as well. Now, the other category of vitamin K molecules is vitamin K2. That itself is a category. There are many subtypes of vitamin K2. They're designated by numbers like MK4, MK7. It goes all the way up to, I think, MK13 or MK15 now. I'm not sure how many have been discovered at this point, but they don't have the same activities. So as what we know in biochemistry is that if you change one carbon atom on a molecule, you can get overlapping activities, but you also get very different activities in the body. And this demonstrates that. So I'll give you an example. All forms of vitamin K, whether it's vitamin K1, MK4, or MK7, will change a blood test marker called undercarboxylated osteocalcin. Undercarboxylated osteocalcin is associated with osteoporosis and fracture risk. So vitamin K1, we know, improves that blood test, but I've already told you that, look, the research, if you look at the clinical trials, it shows with vitamin K1, even though that blood test improves, we're not getting the clinical benefit. The bone density test doesn't improve. It doesn't maintain strong bones in the clinical trial that looked at fractures. Fractures risk was not reduced. If you look at MK4 and MK7, what you get are similar results with MK7. Now, MK7 is a more popular raw material in dietary supplements. It's everywhere. It's very inexpensive to manufacture, and people who market the products with MK7 say, well, it has a longer half-life, meaning it stays around in the body longer, or maybe it's more absorbed. You have to take less of it, and it changes that marker under carboxylated osteocalcin. All of that is true, but none of that are clinical outcomes. None of that is actually a whole person approach. So when you look at the clinical trials on MK4 and MK7, and what we see is MK7, even with bone density, there are multiple clinical trials on PubMed that gave MK7 in different doses to postmenopausal women with osteoporosis. And the women continued to lose bone density. It didn't stop it. It slowed it down, but it didn't stop bone density loss, and it didn't improve bone density. And there are no fracture outcomes data, zero. When you look at MK4, there are dozens of clinical trials, and repeatedly in different types of people taking it, that is postmenopausal women with osteoporosis, for example, repeatedly it's been shown to promote healthy bone density and maintain strong bones in clinical trials, meaning bone density test results improve or stabilize. But most importantly, it maintains strong bones, as indicated by over 70% fewer fractures in clinical trials. And there are multiple meta-analyses on this. It's been so well studied that since the 1990s, MK4 in the dose of 45 milligrams per day in divided doses has been approved by the Ministry of Health in Japan for bone health. So when you're looking at biomarkers and functional assessments for whether a nutrient is going to help, you want to look at, first of all, the clinical trial data. You want to look at not just undercarboxylated osteocalcin or other markers like CTX and NTX. Those are bone turnover markers that can be improved by some of these nutrients. For example, MK4 has been shown to improve CTX in clinical trials. Collagen has been shown to improve, as a hydrolyzed collagen as a supplement, improve CTX in clinical trials. And that may be helpful in terms of patients and them feeling comfortable that they're getting some benefit along the way, because you can test bone turnover markers more frequently than we can test a bone density, or repeat a bone density test. Typically, a bone density test is repeated, every 18 to 24 months, but you can retest those bone turnover markers more frequently. So people who want to have that data, want to see that they're moving in the right direction, or clinicians want to see that there's compliance, can opt to test those. But I just would caution people not to overemphasize the benefits of those, because there are no clinical trials showing that if you just lower CTX, just like if you simply improve undercarboxylated osteocalcin, that fractures improve, because it's a very complicated system. I mean, CTX is one fragment of collagen. It's a breakdown product of collagen. But as I mentioned, in collagen as a protein, there are 180 to 200 proteins in collagen. So I do like some lab tests here and there. I'm not a big fan of ordering a lot of lab tests. I do like just on a standard CBC, which is inexpensive, looking at the neutrophil to lymphocyte ratio. So that ratio, if the neutrophil to lymphocyte ratio is too high, that can indicate inflammation, and systemic inflammation is known to create bone loss and is a risk factor for osteoporosis. Additionally, thyroid. We want to make sure that the thyroid is well regulated, even if it's hyperthyroid, or if somebody is on thyroid medication and they're over medicated, that's a risk factor for bone loss and osteoporosis. Obviously, I mentioned vitamin D status. That's an important, test that is fairly standard. One thing too that I think is really crucial and that gets missed a lot on testing is a serum ferritin test. Now, people understand that a complete blood count that shows hemoglobin, hematocrit, and red blood cells can indicate an anemia, especially commonly iron deficiency anemia we see very commonly. But that is a relatively late manifestation of low iron. The storage form of iron is ferritin. And like a reservoir with water in it, the ferritin will decrease before we start seeing changes in the red blood cell indices, the red blood cell counts, the hemoglobin, hematocrit, because red blood cells last for about 90 days. And so you can see the ferritin dropping even before that. Also, the reference range for ferritin is so broad as to be, frankly, clinically useless. I've seen as low as 10 all the way up to over 200 being, quote unquote, normal. But what is optimal? Well, clinical trials looking at ferritin in women showed that when the woman had a ferritin lower than 50, and she also struggled with fatigue, that giving supplemental iron improved her energy and increase that serum ferritin above 50. Now, I personally am a fan of looking at trying to get ferritin up closer to around 70 or 80. But I've had patients come to me and their ferritin was 20. And we always want to, ask about symptoms and how people are feeling and correlate symptoms to lab results as well. But they're obviously symptomatic for not having enough iron, and that can result in hair loss, dry skin, decreased mood, gastrointestinal challenges, brain fog, all of that. Iron affects every system in the body because it's not just part of our red blood cells for carrying oxygen around the body, but it's also important and required for mitochondrial health and mitochondrial function, for creating cellular energy as ATP. So that explains why that energy goes down when the ferritin is too low, and why mood can go down as well. So those are some of the lab tests that I like. And then in terms of supplementing with iron, one of the challenges I had clinically is that a lot of people taking iron complain of cramping, constipation, and nausea, and they have a hard time getting the dose of the iron absorbed that they need to get the clinical benefits and improve on those lab tests. And so I created a product that's highly absorbed, does not cause any of those GI complications, and we actually guarantee on serial testing that it will stabilize or actually improve that serum ferritin number. And that was an important clinical consideration for me, because I was really frustrated, and I continue to be so, with the industry when companies create products and they cite studies of clinical trials, and then they end up using a dosage of the nutrient that is lower that was actually shown in the clinical trial to work, or in some cases I've seen them use a completely different nutrient than what was even cited in the clinical trial. Yeah. So in terms of functional assessments, just quickly, because there's a lot here, I know, but I think clinically, and for anybody listening, an important functional assessment is just watching how somebody walks. I would always greet my patients in the waiting room and walk with them, see how they stood up, because 95% of fractures occur because somebody falls. And so anything we can do to improve strength and stability and gait is important for reducing their fracture risk. And in fact, grip strength declines, it's associated with increased fall and fracture risk. Or thinning skin. If somebody's skin has become more fragile and thinner and it tears easier, that was associated in one study with bone loss as well. So there's some of these functional markers that exist that don't require sophisticated laboratory testing. It just requires us to be very aware and looking and observing the whole person.
Oh, John, you just opened up so much, and this is so exciting. First of all, I'm going to go back here because, correct me if I'm wrong, but are you telling me that food is medicine?
Absolutely, without a doubt.
That was, amazing. I love that you talked about getting the nutrients from food. That bone is a lot of protein. People don't think that protein is part of what you need for healthy bones. So I love that you touched on that, and the collagen piece, and how the minerals interact and how that is best absorbed from food, right? And those kind of things. I love that you touched on calcium and the limits and what you've seen in studies, because so many women that I see specifically, they go in for a physician appointment and the physician says, yes, here's your 1,000 of calcium or something, just give you, a supplement without talking about lifestyle or diet or exercise or the other things that are going to help their bones. So I think that was amazing. Talking about vitamin D at that 2,000 IU level is probably going to be enough for most people, and that testing is important, right? That is kind of a good thing to look at. And then explaining all the things about vitamin K. Holy cow, we just learned so much today. My question now on that specifically, does vitamin K need to be paired with vitamin D? I know that's one of the, people are learning about, oh, can I take vitamin D? Maybe I need to have it if I need vitamin K with it. It doesn't work if there's not vitamin K. What can you tell us about how to combine those nutrients for those basic supplemental recommendations?
So I always go back to the clinical trials. And I want to see what the clinical trials show, not just what theory shows.
Right.
Because theory too often in medicine, when it comes to actually clinical outcomes, gets proven incorrect. Mm-hmm. And in clinical trials of the MK4, what we see is that MK4 by itself, 45 milligrams per day in divided doses, promotes healthy bone density. It's been shown to improve bone density and maintain bone strength. When it's paired with vitamin D3, however, the increase in bone density is greater than MK4 by itself. So that's why in the products I created, for bone support, it does have the MK4 in it in the clinical trial dose with the D3.
Okay. And so then can we go into some of the products you've formulated for bone health? We're talking about, do you recommend vitamin K and D standalone, or do you have a product that includes calcium, or how do you determine what kind of supplements you should be recommending?
So for me, and I want to be clear because we're talking about, osteoporosis. We've talked
Exactly.
about, we've used that word. The dietary supplements are not approved by the FDA to diagnose, treat, or prevent or cure a disease. What the research shows, however, is that targeted nutrients used in the right way and in the right doses can powerfully promote health, can powerfully move our biochemistry and our physiology in the direction of healthier, more vibrant health. So what we see with the clinical trials with MK4 and vitamin D3, and I was looking at this 20 years ago. I got frustrated, 20 years ago when I was working with patients and couldn't find the doses of nutrients shown in clinical trials to work. So I was the first person, my first company in the country to bring MK4 into products in the clinical trial dose combined with vitamin D3. And now I have 3 versions of that same basic formulation. OsteoK has 45 milligrams of MK4 per day, plus vitamin D3 with 1,000 milligrams of calcium per day for people who need higher amounts. And then OsteoK minis, same MK4 dose, same amount of D3 with 400 milligrams of calcium per day for people who don't need as much. And then now there's a calcium-free or no calcium version called Osteo MK4, which is just the K2 as MK4 D3 combination, all with the same strong bones guarantee that we offer.
Amazing. And I think that's really critical to talk about the different versions of the blends, because people are unique. And when you're talking about a whole person approach, you have to look at that person from a unique standpoint. Everybody's different. Everybody has different levels. So that's amazing. And I'm also talking about assessments. We talked about the testing, but I really like that you brought in the gait and understanding grip strength and some of those things, and the skin and how that could actually correlate to risk factors in the future, or how their bone health actually is measuring up currently. But here's the question is, what does the research actually say about reversing osteoporosis? What are conditions, and to what degree can bone density genuinely be improved?
Well, like I already mentioned, adequate amounts of protein can account for 2 to 4% of bone density, just that alone. And I've seen it clinically where people have not been, their bone density tests have not been, improving. They seem to be doing everything right, but then they're not getting that basic crucial raw material that the bones need, enough protein, even though they may be eating a lot of plants and getting all the fiber and all those other nutrients. And when they increase that protein amount, lo and behold, on the next bone density test, typically the bone density can improve. Now, beyond diet, in terms of improving bone density test results, what the research is clear that exercise is crucial. Weight-bearing exercise absolutely can improve bone density. Now, it's important to do it safely, and I'm very cautious when it comes to recommending specific things that people should be doing, because it's not just what type of exercise you're doing, but are you doing it safely? And is it something that you can continue to do for months and years to come? Because these are typically a clinical situation where it didn't happen overnight, and it takes new habits and really exercising for quite a while, weight-bearing exercises to improve bone density as well. But it's not just bone density. I'm also looking at fracture risk. So somebody doesn't want to immediately go and lift weights because for whatever reason, they're not healthy enough to do that. They're just not interested in doing that. There are many other things that have been shown to reduce fracture risk. And even just walking, 7,000 to 7,500 steps per day is associated with a 50 to 70% reduction in all-cause mortality. And so look at those statistics and that data, it's easy to see that there is a holistic bone health program that can meet everybody's need, meet them where they're at. It can be individualized. And then with respect to, improving those numbers on the test, as I mentioned, the nutrients in dietary supplements, that MK4 and D3 combination, without a doubt, has been shown to promote healthy bone density on testing. And then beyond that too, another risk factor that I would just like to mention is sleep. Insomnia, not getting enough sleep, is associated with faster bone loss. And now there are no clinical trials saying, hey, let's look at improving people's sleep and then track their bone density. But what we do know is that when people don't have enough melatonin, they end up having sleep problems. And again, not getting enough sleep is associated with osteoporosis and faster bone loss. And there was a clinical trial that was done a few years ago that looked at taking 1 milligram and 3 milligrams of melatonin per day in postmenopausal women with osteopenia. And it showed that both doses statistically and significantly improved bone density. Now, the 3 milligram dose gave a greater benefit than the 1 milligram dose, but both improved bone density in that study.
Okay, that's fascinating. Thank you for sharing that one. I want to dive a little deeper because we're talking about lifestyle, right? Movement, exercise, weight-bearing exercise, walking, sleep. How does metabolic dysfunction, chronic inflammation, and hormone imbalance, how do those contribute to bone remodeling? And how do you prioritize them when you're putting together a plan for someone?
That's a great question. I mean, human biochemistry and physiology is a web of interactions, so they're all affecting each other. I don't think that we need to prioritize just one at the expense of everything else, because it is this interactive, web. When you're talking about what to prioritize first, some of it comes down to what the lab tests show, what the symptoms are, what type of medical conditions other people are coming in. Oftentimes, by the time they get to the highest risk category for osteoporosis, which is postmenopausal women, may have other things going on. But I'm a big fan of hormone replacement therapy with bioidentical hormones in both men and women. And the research is clear that in men, a drop in testosterone is associated with bone loss and osteoporosis. But it's not just testosterone. And this is one thing that's I've got my second edition of my book, Fracture Proof Your Bones, is coming out in a couple of weeks. And it has a whole chapter now on testing that expands upon what I talk about in the first edition to talk more about men as well, and other categories of people who struggle with bone health, like people with cancer, autoimmune diseases, and how to approach these. Now, with men, one of the overlooked things for testing is to test their estradiol as well, because it's the estradiol in men that is also responsible, like it is for women, at supporting bone health and promoting healthy bone density. Men typically, we would not supplement with estradiol, but testosterone is converted to estradiol. And so giving them enough, getting that testosterone into that healthy range will increase the estradiol. And so we just want to monitor both of those to make sure they're in that healthy range for bone health and other systemic health. Similarly with women, if estrogen's dropped, then not only do we see an increase in bone loss, but estrogen is also anti-inflammatory. So we have increased inflammation. So we talk about the chronic inflammatory component in bone health and how destructive it is for all systems in the body. Well, if estradiol's gone down, that actually helps. That increases the inflammation. And so just supplementing with estradiol and progesterone, when appropriate, can help reduce that inflammation. But also when estradiol goes down, it affects the gut microbiome in a negative way. There's a strong gut-bone connection now that's been well defined. And in fact, the research shows that when estrogen decreases, our ability to absorb vitamin K also decreases. And so there are lots of reasons to look at hormones, but when it comes also to chronic inflammation, obviously we want to look at an underlying cause. If there's something causing and creating that chronic inflammation, we want to deal with it and try and get rid of it. Just like if we can identify the underlying causes for bone loss, we want to get rid of that, because bone loss and osteoporosis is essentially a condition of imbalance where the destructive forces are winning, and we need to try and rebalance that system. One of the overlooked things that's causing bone destruction that is a common problem are medications. There is a long list of conventionally prescribed medications that destroy bone and increase fracture risk. So much so that I've got a whole chapter on it. Conversations to have with your doctor, questions to ask to make sure that what's being prescribed is not actually one of the things that's causing your osteoporosis. And a lot of doctors who are prescribing these medications are unaware of that side effect. They're not commonly known for most medications. So when it comes to looking at underlying causes, can we identify, for example, with inflammation, is there something going on that's causing it? Is there a dysbiosis in the gut? Is there immune activation because of chronic food intolerances? Are there environmental toxins that are going on? Now, this doesn't require an extensive evaluation for every person all the time, but there are questions to ask to try and understand, what are the most probable causes, and let's approach those first in a very systematic way to see if we can get results, and then adjust as we move forward. And so, but when you're dealing with one system, you're going to deal with all the systems. So when you're dealing with inflammation, if you're improving your diet, that Mediterranean dietary pattern, those whole foods that we're getting, those are anti-inflammatory. And so it's going to help with that. And that may be one mechanism by which it's helping with bones as well. And so thinking holistically, it's not a matter of making, for me, a blanket statement like there is one thing that is the most important thing to do for every person. No, it's individualized approaches and meeting people where they're at. There are so many ways to start to approach this. Some people may be interested in just HRT initially. They're not interested in diet. Well, am I going to turn them away? No, I'm going to meet them where they're at and continue to encourage them. Or they may not be interested in exercise. Healthy exercise also can help improve sleep. Sleep deprivation can create inflammation. So it's all this interconnection. But if they're not interested in exercise right now, am I going to turn them away? No, because the research has shown that if somebody begins to be proactive and improve their health in one domain, let's say they just want to start with diet, or maybe they only want to start with exercise. The research shows once they start to have some successes in that, they start living healthier lives in other areas as well. They may have better sleep habits. They may improve their diet, because success breeds success. And I want people to feel better as quickly as possible.
Oh, thank you. This is really powerful because we have a lot of providers, practitioners, health coaches listening to this. And I would say many of them are, or all of them in this audience are taking an integrative approach or taking a whole person approach, but not bone health might not be the top priority for them. However, as you just explained, it's just part of the puzzle. It's all linked together. When we fix one system, we actually start looking at all the other systems to have improvement as well. And I'm just thinking from the conversations I have with clients, now I can say all of these things I'm recommending are also good for their bones, right? It's really powerful. Shifting gears just a little, there are plenty of women postmenopausal who've already been diagnosed and who've already been putting on different medications. How do you approach the conversation with patients who already have prescribed medications or other pharmaceutical interventions? And is there a role in the whole person approach alongside with those treatments?
Absolutely. Everything that I talked about can be done in combination with the FDA approved osteoporosis medications. It's not either or. It can be and. You can do it all. Now, whether somebody chooses to take an osteoporosis medication, is their choice. Whether they choose to change their diet or start exercise, it's all their choice. It's the concept in medicine called informed consent. And I view my role as a role in education, helping people understand, first of all, what questions they can ask the prescribing physician to make sure they're getting the best recommendation for their health. So when I look at the medications, I like to frame it all around, one is fracture outcomes, because that's the bottom line. Even the American Academy of Clinical Endocrinology has concluded that the improvement in bone density caused by the FDA-approved medications only accounts for 20% of the reduction in fracture risk. Right? So it's even if your bone density is going up with a drug, it doesn't mean necessarily that your fracture risk is declining. And in fact, the definition of treatment failure, that is, when do we know that an osteoporosis medication isn't working? It's only after you've broken 2 bones. That's the official definition. Now, when I look at the medications, there are definitely people who could benefit, and there are people who it's less certain that they're going to benefit. So first of all, in order to get the benefits of an osteoporosis medication, you have to take it about 80% of the time. So it's something you've got to commit to. And so understanding how is it going to be taken, like a bisphosphonate, an oral bisphosphonate, where you have to take it on an empty stomach and stay standing for 30 minutes. Are you going to be able to do that month after month, year after year? Or is it better to get an infusion every 6 months or every so often? Is that going to be better? Understanding the side effects profile, and is that a risk that you're comfortable with? Those are important conversations to have, because what we see, at least with the oral bisphosphonates, is that after 12 months, well, first of all, about a third of patients never even fill the prescription. And after just a year, over half of them quit the medication because of side effects. And so committing to taking that, and there are people who do, they take it just fine for years. And then the question is, well, yes, it's going to improve your bone density, but is it actually decreasing your fracture risk? And what the studies show, and what's important to understand, is that there is a difference between what's called primary fracture prevention and secondary fracture prevention. Primary fracture prevention is, has somebody had a fracture with osteoporosis, and are we trying to prevent another one from occurring? That's secondary. Primary fracture prevention, if somebody has not had a fracture with osteoporosis, we're trying to prevent a first one from occurring. If they've already had a fracture and we're trying to prevent another one from occurring, that's secondary fracture prevention. For primary fracture prevention, the medications are less effective at preventing fractures than they are for secondary fracture prevention. And so there is a case to be made that somebody might get more benefit from the osteoporosis medication if they're trying to prevent a second or third fracture from occurring. So those are questions to understand, and that I go through in my book, and what the data show, how to ask your doctor and how to understand these, because there is different benefits depending on the clinical situation.
Thank you for that. That was a great breakdown of risks and benefits, and how it's a choice, right? And how do we take the medication? How do we support someone who's taking that? So thank you for breaking that down. This has been a great discussion so far, and I want to make sure we get to some audience questions and answers. So thanks everybody who's posting. We're going to get to as many as we can. And if you happen to be watching this as a replay, feel free to post your questions in the comments, and don't forget to subscribe to never miss a live stream. Okay, we have a new question that just came up. Debbie Justice from YouTube asked, I have osteoporosis and recently broke a rib. The doctor told me to take pain pills and go home and put my feet up. He told me my bones are porous. What do I expect? He also told me food doesn't matter. What can I do?
This makes me so sad to hear this, and yet it's sadly common as well. So first of all, most conventional physicians have less than 1 semester of nutrition education in their entire 4 years of school. So I want to start with that, because their education is really not serving them when it comes to talking to patients. And I think that there are a lot of doctors who are very well-meaning and well-intentioned, but like people in general, sometimes they speak in absolute terms when they really haven't looked at the research closely. Diet does absolutely matter, without a doubt. Everything that I just recommended earlier, that's in my books that I teach, that is what you should follow. Then, however, when you're looking at, healing from the rib fracture, I'm sorry that happened to you. What are some options that might be helpful? Well, prescription calcitonin, salmon calcitonin prescription nasal spray, may be helpful at healing, to help that bone heal. Taking some herbs that have been shown to promote healthy inflammation. And there is a whole, fracture protocol that I would use with my patients when I would help them to heal if they did break a bone or if they sprained an ankle. And that would help to balance that inflammation, to help bring that down, to help the bone heal, and then providing the nutrients that are necessary for bone healing. Like I mentioned, the protein. But also, I would recommend people consider, taking MK4, looking at one of those 3 products that I created, because the MK4 was shown in an experimental animal study to improve healing from a fracture, meaning it decreased how long it took for that fracture in the animal to heal. And then I would also look at, taking vitamin C, because vitamin C, again, knocking down that inflammation, helping to balance that inflammation, making sure that you're getting enough sleep, which is crucial for healing. Taking a multivitamin, having some good multivitamin and mineral support, can be helpful. So there's a product I created called Arthro Balance, which is the clinical trial doses of herbs shown to help support and balance healthy inflammation. And that's something that I recommend strongly. In fact, I take it every day, but I would recommend that to take a look at that, maybe discuss that with your healthcare provider. But there are absolutely things you can do to help heal and to help your bones be healthier. And I'm sorry that was the response you got from your doctor, but it's just not based in, I think, clinical experience or the latest research.
Thank you, John. Sadly, we hear that a lot, that people are just getting this, we can't do anything about it. Here's your medication, relax, just rest. It's going to be okay. So I love that you're empowering us, educating and empowering us to be able to take action to support our health and healing, despite the situation or where we may be in. Now, most patients with osteoporosis are also dealing with other chronic conditions. Some have autoimmune issues, gut dysfunction, thyroid imbalances that can also affect bone metabolism. What's your approach when you're trying to address bone health, but the root keeps pointing somewhere else entirely?
That is a great question. So most commonly what I see is in patients, a medication they're taking is creating the bone loss and the osteoporosis. So definitely that is a non-negotiable for me, is a medication review. Have your physician review your medication, but I think importantly, take to your local pharmacist. Pharmacists, I think, are the most educated when it comes to medications in our healthcare system, and I think they're the most underutilized healthcare professional. A lot of times they're just filling prescriptions all day, and yet they're so well educated, and they have access very easily to the latest databases to look this stuff up. So a medication review is really important. When it comes to autoimmunity, chronic inflammatory response, it is complicated. I'm not going to minimize that. And it may take some time to really uncover, if possible, what is going on. Now, there's a lot of documented causes that are associated with autoimmune diseases. They include chronic gut inflammation, dysbiosis, exposure to environmental toxins. And so there are tests that can be run. There are clinical symptoms that can be run. So, for example, somebody has gas and bloating and postnasal drip, those are very sensitive indicators that something's going on with your immune system. And that could either be a dysbiosis in the gut, or it could be a food intolerance, or frankly, it could be both. And so running some testing, which I'd like to do, for an IgG 90 food antibodies test with a stool test, a microbial stool analysis test, can give those answers to start creating a very customized, personal approach to helping people to get better. Cleaning up the diet, I think, is crucial, especially when it's with autoimmune diseases, to really try and avoid anything that's going to tax the system. Giving liver support, making sure you're eating as much as possible, organic foods, and drinking, clean water, and managing your stress, because chronic elevated stress is a well-known risk factor for the development of autoimmune diseases. So again, it comes back to this holistic approach. It takes work. I've had patients come to me and all they've wanted me was to do is prescribe a pill to them. And I've just respectfully said, I'm not your doctor then. I can't do that. It's just, my approach is not right. And that's okay. I respect that. That's where they're at. But when it comes to these chronic conditions, doesn't matter what it is, the holistic approach, the integrative approach, the approach that does require people to create healthier life habits, is by and large the best approach when it comes to creating better clinical outcomes. Because if it's just a medication, the benefits for reducing what are called, adverse clinical events, tends to be relatively low, even if you look at statins, what are quite popular. If somebody's not in a high risk category for a heart attack, you're talking about an absolute risk reduction by taking a statin of only about 1 to 3%. But if you use lifestyle medicine, if you use integrative approaches, you can get much better results. And you can use them in combination. There's no reason not to. Somebody can take a statin and do the lifestyle stuff. Somebody can take a osteoporosis medication and do all the lifestyle stuff. The more you can do from an integrative, holistic perspective, when it comes to diet, sleep, lifestyle, those foundational approaches, the better everything's going to work.
Awesome. I want to know, how can people learn more about you, where you're working, your book, your supplement line? Tell us a little bit more about how we can learn from you directly.
Thank you for asking. The best place to learn about me is on my website, which is nbihealth.com. NBI stands for Nutritional Biochemistry Incorporated, because I love nutritional biochemistry. nbihealth.com has lots of free articles on there. A link to my book is on there. And you can look at the products that I formulated and learn more about my work and my company, and how hopefully my resources might be able to help you.
And when is version 2 of your book coming out?
In 2 weeks.
All right. This is exciting. This is really exciting. So thank you for joining us today. And thanks to everybody who's been listening. If you are listening to this on a replay, make sure you drop your comments and questions so we can get those answered for you at another time. And we will make sure that we post all of the information, so you can find the information on John's latest book, his supplement company, and different protocols, and how to incorporate this into your practice as well.
Thank you. And I would just, if I just encourage people to, if they go to the website, sign up for the newsletter, because when the new book comes out, they'll get an announcement for it.
Awesome. That'd be great. Everyone sign up for the newsletter. I'll do that as well. Thanks, John. It's been a great conversation. You have a great afternoon.
Thank you. You too.